Uh, my talk is quite different, and he told me to talk on Pentacam for PHAKIC, and I was wondering what am I going to talk. But then I realized that there are many things which we can take up, and I have kept this presentation more of a problem-based learning. So it's a case-based scenarios where I'm not going to talk much about the detail of theories and everything. I do not have any financial disclosure here. Uh, Basically, when we talk about phakic oil, we are essentially referring to ICL and IPCL, ciliary sulcus fitted oil currently. And I do not have any financial disclosure with either of them. So the question arises, why do we need topography before phakic oil? I mean, it's not mandatory. They don't tell us to do that. So let's see one example. A young male with compound myopic astigmatism was come for the phakic IOL, and everything was fine except the left eye vision, best corrected vision was not 6/6. And when we look at the pentacam of this gentleman, you realize that there's significant asymmetry on the corneal curvature in the central visual axis area. Now, this is not the best thing. Without topography, you would seldom be able to pick up this kind of asymmetry. Now, what happens that whenever we do either say keratometry or anything, we just average out the meridians, and finally we end up actually averaging out everything. So in absence of any topographic instrument, you would not be able to see the asymmetry on surface. And if you do not pay attention to this thing, your visual outcome may not be the best, because this person, you're just going to treat the lower order aberration, sphere and cylinder. And this asymmetry is going to be quite glaring, and patient might have severe ghosting. So rather than just phakic oil directly, I might want to resurface the cornea first and then think of phakic oil. So corneal topographer, whatever you have, would be must before I go ahead with any phakic oil. The second question is, why do we need tomographer or elevation-based topographer? Let's see another case. Now, another gentleman, this time mixed astigmatism, has turned up with a report which is a placidus-based topographer eye trace report, and which essentially says it is normal, and the previous clinician had taken a central pachymetry value and which ultrasound pachymetry value, and which showed that 500 micron in right eye and 510 micron in left eye, which if you look at both of these things, well, they would look normal, and essentially you can think of going it with refractive surgery. If you look at the pattern, well, this pattern seems to be with the rule astigmatism pattern, and I would be quite okay with that. However, can we go ahead with LASIK here? And when we did a pentacam, we realized that the thinnest point, unfortunately, wasn't in the central part of the cornea, and hence the person who had taken the central pachymetry wasn't the thinnest pachymetry, and the thinnest pachymetry was 475 micron. And in such kind of cases, I would not be very keen on doing laser refractive surgery. And such cases, I would rather go ahead with the phakic IOL. And hence, such kind of cases where there can be changes on the posterior surface, or the thinnest point may not be in the center part, your elevation-based tomographer or your pentacam kind of devices can actually pick up these things, and they can be better than your placidus-based topographer. The question arises now, yes, we agree that elevation-based topographer can be better than the placidus-based topographer. Now, question arises, there are many of them, and why we talk about pentacam alone? Well, let's take one more case. This time, a young lady who was interested in LASIK turns up with a refractive error of 6.5 diopter, not much of a significant history. Both the eye maps look pretty decent, except a small posterior elevation, which may not be as significant. But having said that, previous speaker did speak about those things. We'll come to that. But one side of my brain said that, well, go ahead, it's fine. Yeah, pentacam normal, good pachymetry, robust thickness, best corrected vision, 6.5, only sphere. Why should we worry? Whereas the other part of my brain said, can we miss something on a shine flip based topography also? And then the answer is that if we look at the Belen-Ambrosio enhanced ectasia or exclusion map, we see that there is a possibility of a small hidden cone on or the posterior elevation of formophrastic keratoconus in such case. And I won't be very keen on any weakening procedure, and I would rather look at something which possibly gives me a little more stable cornea, such as phakic IOL. So if I have a elevation-based topographer such as Pentacam, in such kind of cases, I may actually end up choosing proper case for my phakic IOL. So I would say probably this would be something which I would keep in mind. The next question, how do we use Pentacam for phakic IOLs? Now, practically speaking, whenever we talk about phakic IOL, the most important outcome measure where what we look at in phakic IOL is vault. The vault we know is nothing but the gap between posterior surface of the lens and the anterior surface of the crystalline lens. And the vault, ideal vault has to be from 250 micron to around 750, 800 micron. If the vault is very high, there can be pigment dispersion, angle closure, endothelial damage. If the vault is very low, there can be chance of cataractogenesis or rotational instability of the lens. When do we accurately estimate the vault? Well, post-operatively, it depends upon the method you have taken. I prefer hydroinsertion, where I insert my lens under saline. Again, there's nothing right and wrong here. Whatever works in your hand. I do not want to say that hydroinsertion is the only way or that's the best way. Whatever works in your hand, it's fine. Now, with hydroinsertion, because there's no visco behind or in front of the lens, the vault becomes more reliable pretty immediately. Whereas in case of visco insertion, if the residual visco is in front of the lens, the vault can be falsely low. If it's behind the lens, vault can be falsely high. So depending upon what kind of method you have chosen, you can have an idea about the vault. And when come back to Pentacam, though Pentacam can actually show you the vault. In fact, this was the first diagnostic device which showed us the vault, and this is how we used to measure the vault. As you can see, a low vault here, but later on when anti-segment OCT came, it became much better way of measuring the vault. But having said that, Pentacam can still give you a vault where you can get a fair idea about the vault. The parameters required for phakic IOLs for the sizing, most important parameters are AC depth and horizontal white to white. Now, anterior chamber depth can be measured using different devices, from contact devices like A-scan, ultrasound A-scan, or UBM, or optical devices like optical biometers, or tomographers such as Pentacam. We prefer to measure it from endothelium to the anterior surface. You can also use anterior segment OCT, but Pentacam does work very well. The important part, apart from the anterior chamber depth, is the iris topography, what we can get on Pentacam. So we can see iris configuration, whether iris configuration is convex, flat, concave, whatever way, and that's equally important, just not just the center anterior chamber depth. The second parameter, white to white measurement, ideally is supposed to be measured using a digital caliper in supine position, in patient in supine position, and under surgical microscope from mid-limbus to another side of mid-limbus. I always would suggest that we use two devices to confirm that one digital caliper, which I use as a confirmatory device, and primary measurement I take from an optical device, which can be anything. It can be your topographers like OpScan, IOL Master, or my preferred method would be Pentacam. Now, please remember, the measurement taken from different devices can have significant variability. As you can see from here, my own right eye measured on different devices has significant variability. So you cannot keep interchanging the devices, and then probably try to assume the correlation between them. It does not happen. But the interesting part about Pentacam, why I love to use Pentacam here, is that what I prefer the direct measurement, what I personally take, where I take the horizontal Scheimpflug image, I do the image inversion, I take my digital caliper, measure the horizontal white to white there, which is like essentially measuring on a patient. This thing which I get, I feed it on my digital caliper and then put the patient on a slit lamp or a surgical microscope and confirm. Now, this way, it's more reliable and it's not first Perkins based image measurement, which normally most of the instrument take. So as you can see here, this is the direct image of Scheimpflug, then image inversion. I take that measurement, feed it on my digital caliper, and I just confirm that am I accurate or not. And this gives me pretty accurate white-to-white measurement, or more repeatable white-to-white measurement, rather than taking an advantage of first Perkins image-based measurement, what most of the intuitive measurement are given by instruments. Why Pentacam for phakic IOL and keratoconus? Now, when we talk about keratoconus and phakic IOL, we usually agree that it should be reserved for the visual rehabilitation purpose. Very useful for keratoconus with action myopia or significant myopia, best suitable for central cones. Now, when we talk about such kind of thing, let's see one example here. A young male with significant myopia and keratoconus underwent cross-linking and had a decent vision. And I promised him that we will definitely do a phakic IOL. I did an ICL, and post-op outcome was exhilarating, 6/9 vision, and I was very happy. Unfortunately, patient was not, because patient had uniocular diplopia, ghosting. The reason was patient had a decentered cone. So I treated the lower order aberration sphere and cylinder, but the comma part, which was induced by decentered cone, was right there. And in fact, when I treated the higher order aberration, the comma became so enhanced that patient was not happy, and I had to go ahead with the second procedure of topoguided treatment on top of that. So topography is must before doing a phakic IOL. Now, let's take the second example here. One more patient of mine, again, a lady who had come to me for treatment. When I saw this cone on Pentacam, and I was like really excited that a central juicy cone, and I would be really happy to do the treatment, because even the AC depth was like 3.2 millimeter internal depth. So I said, don't worry, we'll do cross-linking and followed by a phakic IOL. I promised her that, but later on when I realized that after the treatment, when I looked at the topographic axis, which was 70-degree steep meridian, and there's no doubt about this thing. But when my optometrist gave me the refraction, he said the steep axis is 20-degree. There's a 50-degree difference between both of them, and I tried myself, but patient would not accept it. Now look at this thing. Intuitively, it looks patient cannot have any other axis but the steep axis at 70, but subjective acceptance was totally different. As we treat subjective acceptance with phakic IOL, ideally we have to go ahead with the refraction. But looking at this cornea, I seriously cannot accept that the refraction can be like this thing. And ultimately, I decided possibly this was not the best case suitable for my phakic IOL. So when in doubt, please avoid it. And this is what was the advantage of using a Pentacam or a topographer. Many times in keratoconus cases, the central anterior chamber depth what we get can be falsely high, because the cone which is there in the center part actually mimics a high anterior chamber depth, and which is possibly a false anterior chamber depth. So when we do phakic IOL there, we may end up in crowding of the angle and high vault. So be aware that whenever you do such kind of cases, look at the Pentacam and look at the peripheral AC depth and overall view of the anterior chamber. So to summarize, why I prefer Pentacam for PHAKIC IOLs: one, to assess the topographic irregularity in these cases. Second, to rule out any early keratoconus, or to avoid any laser refractive surgery, where I can rather do such cases as PHAKIC IOL and not laser refractive surgery. For the pre-op sizing, I prefer anterior chamber depth on Pentacam, and also would prefer to look at the iris configuration. White to white measurement I would prefer on Pentacam, especially using the digital caliper there on image inversion, and post-operatively can be used to assess the wart. Thank you very much.